Next slide.
Yes, sir.
So the size was around 2 by 2 centimeters.
Yes, sir. According to the patient, it was 2 by 2 centimeters when she first noticed it, and then in a duration of 10 years, it gradually progressed to present size, which was approximately 20 into 25 centimeters in length.
Almost 10 times.
Yes, sir.
10 years
It increased by 10 times.
And so, again,
Yes,
that
sir.
pain, initially is it the same type of pain or the dragging has increased? Do you think it is because of weight of the swelling or is it what other reason?
Sir, mostly it is because weight of the swelling, because patient had not noticed the pain in the initial stages.
Right. So, whereas it is the dragging pain because of the
Weight of the swelling. No history of trauma or fever or weight loss or numbness or loss of sensation over the skin, and she has no complaints of restrictions of the movement or mobility in the lower limb. She has no other similar swellings elsewhere in the body, and the patient had directly come to civil hospital for evaluation and management. Sir.
So, trauma, yes, we usually ask history of trauma, but when it is a 10-year-old swelling, probably does not have any
Significance with the swelling.
except for probably a bone.
Thank you.
Malformated bone, we should have a callus formation over there, which grows with the hematoma. This is the likely possibility. Right? Why do you ask for fever or weight loss?
Sir, any recent change? It could have been a secondary abscess formation, so I asked for fever and weight loss because possibility of a malignant lesion and which is slow growing.
Right. Numbness and loss of sensation?
Sir, it could be compressing over the surrounding vasculature and also the nerve structures. Yes, sir. Neural lipoma. Yes, sir. Past history, she has not a known case of hypertension, diabetes mellitus type 2, bronchial asthma or pulmonary TB and epilepsy. She has no history of any past medical illnesses, no history of prior hospital admissions for the same complaints, no history of any known drug allergies or previous medications. Patient underwent 2 lower section cesarean sections in 1994 and 1998 with tubal sterilization in the latter one. Personal history, she has been married for the last 28 years. She is a vegetarian. She has normal bowel and bladder habits with normal appetite. She has a normal sleep-wake cycle and she has no addictions.
Considering that this swelling is on the lead,
Yes, sir.
of the abdominal history and all those things are present muscle history, not a much significant except for promoted diabetes.
No similar family history in the family. And
So what do you want to point out when you talk about family?
sir, sarcoidosis or any malignant lesions will be in the family with gene-related
Not malignant lesion, but
gene-related lesions will be. Yes, yes, sir. To summarize the history, a 48-year-old lady presented with history of a swelling in the left side, thigh, lateral side since last 10 years, associated with pain for a month with no history of trauma, weight loss or fever or any other associated symptoms. Coming to general physical examination, patient was examined after obtaining her proper consent in the privacy of a well-lit room accompanied by a female chaperone. She was conscious and oriented to time, place and person at the time of examination. She was well built and moderately nourished. Examination of vitals, her temperature was normal with a pulse rate of 112 per minute in the right radial artery in supine position, and blood pressure was 130 by 80 millimeters of mercury in right arm in supine position. There is no pallor, icterus, cyanosis, clubbing, pedal edema or lymphadenopathy.
Most of the time, the swelling comes in positive, so it will not be clear.
Yes, sir.
You should make it a good habit of taking all of
So coming to local examination, on inspection, swelling was present on the posterolateral aspect of the upper one-third of the left thigh. Single spherical swelling measuring approximately 20 into 25 centimeters in size.
upper one side of the thigh. So what was the height of the thigh? What do you think was the length of the thigh?
Sir, the patient was approximately 150 centimeters. The thigh was approximately 40 centimeters. So upper one that I have divided into 16 centimeters, 36 centimeters.
So the upper half would be a good.
Upper half.
Somebody asked.
Yes, sir.
See, 20 centimeters long with the upper one side is almost 60 centimeters long. Thigh, right?
Upper half.
Upper half would be a good option.
Okay, sir. A single.
Not significant, but see, when you are doing coding exams or somebody is trying to pull your leg, it is like.
The swelling extends vertically from the left iliac crest to the middle one third of the left thigh, and horizontally it extends from the lateral aspect of thigh up to the upper inner quadrant of the left gluteal region.
So 20 by 25 and you are saying it's spherical cell.
Sir, on inspection it looks spherical,
Not oblong.
not oblongs, not oblongs.
And almost that was in that also it is always penetrity.
Sir, yes sir.
Three-dimensional structure. That is three-dimensional. Right? So was it a penetrated swelling or was it part of the swelling?
No sir, it was not a pedunculated swelling. It was a part of it was going inside, and it there is no wasting
So
of.
I would say ovoid would be a good option or circular or rounded shape would be a good option. Because here is a third dimension. If you know the third dimension, then you can get it.
There is no wasting of muscles and no dilated veins or pulsations present
How
over.
do you look for wasting of muscle?
Sir, by comparing it with the other limb.
See, there is wasting of a limb, not a wasting of muscle.
Okay, so basically.
When you speak about the muscle, you have to say specifically about one particular group of muscles. So what you need to say is that both the limbs, see, rather than using a word wasting, you should rather say both the limbs appear normal
Yes.
to each other, except for the swelling part. Both the limbs on gross examination
Appear
normal.
normal. Yes.
Then you may go into detail if you have variation by the caliper or circumference of the thigh to say given point.
No dilated veins or pulsations present over the swelling.
So what type of swelling would have a dilated vein or a pulsation?
Sir, a hemangioma or a cystoid aneurysm will have dilated veins and pulsations present within the swelling.
Again, the 20-25 is a huge swelling.
So, yes.
Hemangiomas are never swelling. Not that it goes, see, two things are important. One is 10 years.
Yes, sir.
It can have a reverse. Or it can have a capillary hemangioma
Capillary.
for a long period. Yes. But then they are not that huge. They are spread over a large area of surface.
Yes.
But not huge. Something that projects out of the body with so much of blood, which looks solid, can never be a human. But AV malformation here.
Yes.
With past history of trauma, there can be a possibility of an AV malformation which has caused that particular swelling.
The swelling becomes more prominent on abduction and external rotation at the hip joint. The opposite limb is normal and both limbs are symmetrical.
Why do you say it becomes prominent on abduction and what do you want to emphasize?
By contracting the muscles of the lateral compartment by abduction and external rotation, the swelling is in the supramuscular plane, in the subcutaneous plane. It is not extending into the muscular plane.
So how do you do it?
Sir, by asking the patient to abduct and externally rotate and making the muscles of the lateral compartment taut.
But you have to give instructions.
Yes, sir, by giving resistance. So these are the images of the swelling which is present on the posterior lateral aspect. There are well-defined margins on the lateral aspect, but it is incontinuous with the gluteal region on the posterior.
So again, see, you cannot say a spherical thing because you don't know the inner aspect. If you take the whole name, it is spherical. Or that particular person, but then more than 50% of it is the normal name.
On palpation, there was no tenderness or
Very
fatty patient. Yes. Yes, sir.
Do you have a post-operative photograph?
Sir, we didn't operate the patient. Sir. Patient has been referred to plastic surgery for liposuction.
Okay. Why did you do that? Why did you do that?
So patient was given an option by sir, so she chose.
No. In the figure. See the first figure when the patient is sitting and standing in front of you.
Yes, sir.
Is there any difference in the two sides?
There is no much difference between the two sides.
So, the picture that you are giving is of the MRI or CT? You will go for an MRI or CT?
We have gone for an MRI to differentiate between any sarcomatous degeneration in the lipoma cell.
Now that is the reason. Why? When it is multiplied by 25 times the swelling and you are not able to appreciate it completely examination here, why did you go for liposuction? Basically because it was a diffuse lipoma.
Diffuse lipoma. Yes.
In a very obvious way. So even if you have removed it, probably the patient does not have been satisfied for an extent that can you imagine 25 is a almost a football size.
Huge swelling.
Right.
Yes.
So if the huge lipoma is there, you should definitely go for it. But you will never know in this patient what is the substantial effect and what is the
lipoma.
It will be very difficult for you to access, and even after you access, probably the difference in the
Composing to the contour will be very. So on palpation, there was no.
Okay, fine.
No tenderness or local rise of temperature. Inspectory findings are well confirmed and have palpated a diffusely enlarged swelling. Approximately 20 into 25 centimeter size single spherical shaped swelling present in the posterolateral aspect of upper half of the left thigh. It extends horizontally from the lateral aspect of the thigh and vertically extends from the iliac crest to the middle one-third of the left thigh. It extends horizontally from the lateral aspect of the thigh to lateral aspect of the posterior aspect of the gluteal region. Yes, sir, of the leg. And vertically extends from the iliac crest to the middle one-third of the left thigh. The surface is lobulated and it is soft in consistency. Yes, sir.
Now, this is the
Yes, sir. Sir, a single spherical swelling which is measuring approximately 20 into 25 centimeters.
It looks more over but there is no obvious
Third dimension.
Yes.
Yes,
You are not running you should make the patient later or slightly oblique, then you are able to figure that. Now you describe and tell me what it is.
Sir, a single ovoid swelling measuring approximately 20 into 25 centimeters present over the posterolateral aspect of the upper half of the thigh, extending vertically from the iliac crest to lower half of the thigh and horizontally extends from the lateral aspect of the thigh to the posterior midline of the back of the thigh. It is soft, the surface is lobular and consistency is soft. And sir,
This is partition.
yes, sir.
So consistency is soft.
Yes, consistency is soft and there is no tenderness or local
There is
tension.
such a presentation, you will always find it to be soft in consistency.
Yes, sir.
Unless until there is a very hard thing inside, or it is very in the substance. It is very difficult to determine is this the surface of the swelling because what you see is a
Diffuse swelling
over a large area.
Yes, sir. Ill-defined margins were present and it was
So it is very difficult unless until you actually okay fine. So it is a soft swelling.
Yes, sir.
It's a typical lipoma.
Lipoma.
Soft swelling, and then
sir, margins are ill-defined and the swelling is freely mobile. Skin over the surface is normal and it was not adherent to.
free mobility of the swelling.
Sir, it was mobile along with the gluteal fat.
That is why I'm asking. Again, a very petty patient.
Mobility
It is
cannot
very
be.
difficult to see the mobility in such a patient.
Yes.
That is in a small patient, the small swelling, this is very obvious on the limb.
Yes, sir.
You can fix the limb and you can try to manipulate the swelling. Contract the muscle, manipulate the swelling. To look for its mobility over the muscle, whether it is intramuscular or it is on the subcutaneous.
Yes, sir. The swelling was not fixed to underlying structures and not fixed to the skin. Skin was pinchable. Good morning, sir.
You start the local examination.
Yes. Sir, a 48-year-old female presented to the OPD with chief complaints of swelling over the lateral aspect of the left thigh, upper left thigh since last 10 years, associated with pain for the last 1 month. Sir, coming to local examination, on inspection, the swelling is present over the posterolateral aspect of upper half of the left thigh. A single ovoid swelling measuring approximately 20 into 25 centimeters in size with lobulated surface, ill-defined margins and the overlying skin appearing normal. The swelling extends vertically from the left iliac crest to the middle half of the middle one third of the left thigh, and horizontally it extends from the lateral aspect of the thigh up to the upper inner quadrant of the left gluteal region. There is no wasting of the limb, no dilated veins or pulsations present over the swelling. The swelling becomes more prominent on abduction and external rotation at the hip joint along resistance. The opposite limb is normal and both limbs are symmetrical. These are the images of the swelling over the posterior lateral aspect of the upper half of the left thigh. So on palpation, there is no tenderness or local rise of temperature. Inspectory findings are well confirmed and are palpated a diffusely enlarged swelling. Approximately 20 into 25 cm sized single spherical shaped swelling present in the posterior lateral aspect of upper one third of the left thigh, which extends horizontally from the lateral aspect of the thigh to the posterior lateral aspect of the left gluteal region, and vertically extends from the iliac crest to the middle one third of the left thigh. It has a lobulated surface and soft in consistency with ill-defined margins. Skin over the swelling is normal. The swelling is not fixed to skin or the underlying surface. Swelling is present in the...
What do you mean by skin over the swelling is normal? In palpation.
Sir, in relation to the skin over the normal surface, the skin over the swelling is also normal.
What I mean to say is, what do you palpation?
Yes, sir.
Inspection is a different thing. When you say inspection, it means that there is no visible vein, there is no redness. I agree with you, right? So what do you mean by skin palpation, skin over the swelling is normal?
So
What normality you expected?
Sir, any calcifications within the skin or thinning of the skin might be present. Sir, to see whether the skin is any underlying changes over the skin, like calcifications or thinning of the skin.
Then what do you mean by skin is normal? What is minimal?
Sir, in comparison to the normal skin present over the limb, sir, there are no
Is the skin fixed or not? That's what I want. Here it is very not fixed to underlying structure. What about skin?
Sir, I have written not fixed to the
How do
skin.
you know that? Okay. What do you mean by that? How will you do that thing? That skin is not fixed.
Sir, by pinching the skin over the swelling and looking for if there is any dimpling or...
Then how will you know that the skin is not fixed?
Sir, by moving the swelling after fixing the swelling, if the skin also moves along with the swelling, then skin is...
So, you know that in lipoma there is a very specific thing. Sometimes when you do lipoma, skin moves.
Yes, sir, due to the fibrous connections with the skin,
How will you know it is not fixed skin and only fibrous connection?
so slip sign can be done.
See, that is for anything. You cannot do What you should use in exams, skin cannot be pinched. All skin can be pinched. A specific word is used. You understand? The point here is that when there is such a large swelling, the skin will be stretched, may be red, but how we will know it is pinched off? Only pinching can tell. But sometimes in a large swelling, it becomes very difficult to say. It is difficult to say whether the skin is pinchable. Even in a large sarcoma or a large sarcoma.
Sir, swelling is present in the subcutaneous plane and no other palpable swellings were present on the limb. On auscultation, there was no bruit present over the swelling. Other systemic examinations were normal. Coming to summarizing the case, a 48-year-old lady presented with a swelling over the side, lateral side of the left thigh since last 10 years, associated with pain in the swelling since 1 month with no history of fever, weight loss or prior trauma. On general examination, she is well built and moderately nourished and vitally stable. And on local examination, there is a spingal, spherical, lobulated, non-tender, soft swelling of 20 into 25 centimeter size in the posterior lateral aspect of the upper one-third of the left thigh. Sir, my provisional diagnosis is a lipoma of the left thigh with differentials being liposarcoma or a rhabdomyosarcoma. Sir, it is the swelling. Patient noticed the swelling 10 years ago, which was initially small in size and it gradually progressed to present size in 10 years duration. Soft in consistency and it has no other pressure effects or any other. Sir, it is a benign neoplasm of the adipose tissue.
How is it different from a normal fat? I say it is a normal or abnormal fat deposition rather than lipoma.
Sir, compared to the normal fat on the other side, the swelling will be. It is
abnormal deposition. One side is less deposited, opposite side is more deposited.
It is lobulated and it is encapsulated and it is a slow growing tumor.
Margins are different.
Yes, sir.
How can clinically you can say it's calculated? When you have said that.
Yes, sir. I said ill-defined margin.
Right? It is ill-defined margin. So, how do you define it is a normal fat? What are the differentiating points? In other words, you should put a differential diagnosis of abnormal fat position before liposarcoma. Why will you not put a diagnosis of liposarcoma before that?
Sir, there has been no any changes suggestive of sarcomatous degeneration.
What are those things?
History of rapid gain, rapid progression in the last few months.
It is there?
No, sir.
No. Okay, so very slow growing.
Very slow growing. There will be history of weight loss and there will be adjacent.
Why there will be weight loss in liposarcoma?
Sir,
Rarely it is any soft tissue sarcoma weight loss unless it is abdominal or related to
retroperitoneal.
Weight loss is not a common thing. Then
pain will be a main predominant feature of liposarcoma.
what type of pain?
Sir, it will be a dragging type of pain if it is involving the nerves and it will be shooting type of
Is
pain.
a common site for development of liposarcoma?
Sir, for myxoid and round type of liposarcomas, posterior aspect. Sir, usually retroperitoneum is the most common site.
One of the common sites.
One of the common site is back and trunk and also lower leg extremity.
Thigh is not a common,
It is common.
Common. Conversion to liposarcoma is common. In a retroperitoneum, de novo liposarcoma develops. Shoulder and the gluteal and upper thigh, those are regions when the normal lipoma can convert into liposarcoma. Anything else? Why this is not liposarcoma?
Sir, consistency is soft. Usually liposarcoma will have variegated consistency with areas.
Not necessary.
And it is not invading the deeper planes. It is only in the subcutaneous planes. Sir,
Suppose it is arising from muscle.
chances of it being liposarcoma is more when it is arising from muscles.
The size have any?
Yes, sir.
What are those?
Sir, it won't be this huge in size and it will be,
What is?
sir, not 20 into 25 centimeter size.
Not liposarcoma.
Rapid progression,
Have you already seen actually? What about the skin?
Skin will be
What
fixed.
about the on inspection?
Sir, on
Only
it,
through skin.
skin will be stretched out and there will be dilated veins will be present.
Are there dilated?
No dilated veins.
Those are the very important point. Increased vascularity will be reflected on the skin. Stretching of the skin, recent increase in size, recent development of pain. You understand? And associated pressure symptoms may be there. Involvement, you can say anything, but there is involvement of nerve, pressure of the vessel, right? So those are the things. There are not there.
Not there.
Okay. What is the rhabdomyolysis?
Sir, another soft tissue tumor which is most commonly,
You say, have you done a test whether it is attached to muscle or not?
yes sir,
So what do you say?
it is not attached to underlying
So
muscle.
why is the differential diagnosis of lipoma?
Sir, patient had recent onset of pain since the last 1 month which was dragging in.
Why rhabdomyolysis? When you see rhabdomyosarcoma, you should see mobility, relation to muscle, more hard, hard inconsistency, skin will not be that much right, and mobility will be restricted from beginning. So remember, rhabdoma, the benign rhabdoma is very, very rare. Conversion from rhabdoma that is very unknown. So long 10-year history without any sudden increase. Rhabdomyosarcoma is not a differential diagnosis. Right? So it leads us to lipoma.
Or abnormal deposition.
Abnormal
Deposition of
rare
fat.
possibility of lipoma. Right? So how do you confirm your diagnosis?
Sir, first I would like to go for a imaging study. After clinically confirming my diagnosis of lipoma or any differentials like liposarcoma or abdominal differentiation, deposition of fat, I like to go with the imaging study to see the characteristics. MRI, sir, MRI for soft tissue will be better. So
Why? Will you do MRI first or a biopsy?
sir, MRI, because if I do a biopsy, there will be artifacts. It will be seen on the MRI.
Why not see this time?
Sir, fat delineation will be much better appreciated on MRI.
So only with I don't know.
Yes, sir.
Suppose this is rhabdomyosarcoma.
Then
Then you will go for a CT. The muscle is very more appreciated in CT.
no, sir. MRI will be
Not
much.
only for fat we do MRI. Okay. Sir, don't find a shortcut because this is lipoma, I will say fat. Why do we prefer MRI over CT?
Sir, MRI will give better imaging study by soft tissue will be better.
But what's better? So what are the advantages? That's what I'm asking of MRI over CT.
Sir, the depth and invasion of the muscles, if at all is present, will be.
Again, it can be seen in CT. So what are the things you see in MRI which is better? The soft tissue and neurovascular compartments are better delimited in MRI. So neurovascular invasion, capsule breach, invasion in surrounding structure, much earlier, not better I would say, earlier in MRI than in CT. Right? So suppose I said I will go only for a cut. I am saying it is a benign condition. Please would you like to do MRI?
Yes, sir.
Why?
Sir, if at all we didn't go for an imaging study and the biopsy will come out as malignancy or any other condition, then we won't have a prior imaging study to see the extent of the swelling.
Okay.
Planning of the surgery will be difficult without any proper
What are the
imaging.
indication of MRI? All patients of soft tissue tumor is undergo MRI.
No, sir.
Suppose this is a 5 centimeter size lipoma. Will you go for MRI or not?
No, sir.
So what are the indication of doing MRI?
Sir, a large swelling,
What is large?
a swelling which is more than 5 to 10 centimeters in size.
I would say it's a very big head. Anybody would like to say? Two things you should remember.
Size.
One, the location and size. Usually more than 10 centimeters is the definitive. So location, certain area. That's why I asked eye, shoulder, you
Yes,
should
sir.
remain more, even 8 centimeter you can go. And clinical
Suspicion.
even a smaller tumor.
Yes, sir.
Suppose a 7 centimeter tumor, But recent increase in size. Patient is having a pain, patient is having a distended veins over there. So it is a high degree of suspicion for more than 10 centimeter size of lipoma, you should undergo MRI. Not all cases. So the lipoma comes in all sizes and shapes. But less than 10 centimeters, usually a long standing does not require otherwise that. So suppose you do MRI and you suspect malignancy, what will be the next step?
Sir, then I would like to go for a histopathological diagnosis.
What?
Sir,
So why?
image guided core needle biopsy will be my investigation.
Why image?
Sir, because when taking a blind, we can get sample from the normal fat tissue also, and we will rule out it as
Particularly in a very large tumor, suspicious of malignancy, whole tumor will not become malignant. That is the one more advantage of MRI. MRI will show you the invasion and increase vascularity site and probable site of conversion easily. So yes, image guide. So would you prefer core needle biopsy or incisional biopsy?
sir, core needle biopsy. If at all I am planning, core needle biopsy would be my first answer, sir. If at all I am
Why? Why? What are the reasons?
sir, it is less invasive when compared to incisional biopsy, and image guided will be much better, sir, because exact area of the biopsy will be.
That is another point you should remember. This is the one area where incisional biopsy may not be superior to tumor. The reason is that area of conversion may be big. The on-incisional biopsy you may not be able to reach there. You understand? When it is a confirmed sarcoma, there is a role of incisional. But when it is suspicious conversion partially, image guided core biopsy definitely will guide you better. Suppose, I think it is benign like this, then you will be
If there is no clinical suspicion of malignancy, then FNAC might suffice.
So, what will FNAC do?
Sir, it will.
No, it is not to be done in such a large tumor, and it has no value. Because it will not give a sample, it can only show the static finding. So it is the role of FNAC in a soft tissue tumor is very limited. It is like, I think, confined thyroid now. Even breast people are saying, but that should be kept in our mind. That it has no value. Okay, so what is the difference between lipoma and normal fat?
Sir, normal fat tissue, the adipocytes are fat is deposited within the adipocytes, whereas in lipoma, the mature adipose fat cells multiply. In lipoma, there are mature fat cells which are covered by a fibrous sheath, and they multiply within the fibrous sheath. Capsule within the fibrous sheath. So in lipoma there is fat cell hyperplasia which is confined within a capsule, whereas in normal surrounding fat there won't be any hyperplasia, but there will be hypertrophy. The cells will get.
Ask this patient to stop.
No sir, lipoma won't disappear.
Why not?
It is not involved in the fat metabolism. And
Why it is not involved? That's what I'm asking.
Sir, it is capsulated and it is not participating in the.
Why they do not participate? Is there any difference in nucleus? Is there any difference of area of deposition?
Yes.
What is difference?
The nuclear fat vacuoles are fat or.
One is in center, one is in periphery. Where it is center, where it is periphery?
Sir, in normal fat cells it is in center, and in the lipoma it is peripheral.
These are you can call immature or deviated fat cells, which is covered by fibrous. So once the these are nothing but an abnormal fat cells which does not participate in metabolism because of that. So that should be kept in mind. This is a silly question, but always asked in exam, and you should be ready for it. Okay, like in this case, the report is suggestive of only fat cells.
Yes, sir.
What is MRI? Show the MRI. What does it show?
Sir, there is only normal fat differentiation with no extension of the muscles into the swelling. And compared to the other limb, the fat deletion is same, and there is no any evidence of sarcomatous changes or any other degenerative changes. And The MRI was normal, sir. Only abnormal fat deposition was given in the report.
Okay. So you do look at now. That's my question. You have said there is a no definite swell.
If clinical suspicion is still there, we can go for true cut biopsy to rule
The diagnosis of MRI, the word you should use is diffuse lipoma.
lipoma.
That is what. If it is painful, you can call it dercom. Otherwise, it is nothing but diffuse lipoma. So can you do a trial of starting this thing?
Sorry.
Yes. The first thing that will come in your mind when you find this picture is
It is abnormal fat deposition, but
it is not a tumor.
tumor.
What which is used, it is not a tumor. And where it is not tumor, it's right. So what can be the cause? Now, the usual cause nowadays is hormonal. You should keep that thing in mind. That should be the one of the reasons. Sometimes without reason. But so, it is not a tumor. You still go for tumor.
If we are clinically suspecting a tumor, then we'll have to go for a true
So
cut biopsy.
irrespective of anything, true cut has definite value. You understand? So can the FNAC suffice in this case? Now there is no tumor.
But if we are clinically suspecting, then FNAC won't be sufficient.
So it will show only the cells. And your diagnosis will not be confirmed. You need whether it's a normal lipo cells or is it
Abnormal.
It can only be better with the true cut.
True cut.
So true cut is optional, but you should do when you suspect that can be a medical. Suppose it is same on both sides, then there is a right and left luteal same swell.
So then it is abnormal deposition of fat, and then
Now what will you do? In that case,
in that case we can offer the patient for starvation and see if the swelling decreases.
so before that you should say, I will investigate for hypothyroidism, investigation for hormonal dysfunction.
Yes, sir.
But which hormonal dysfunction?
Sir,
Apart from hypothyroidism?
gonadotropins and follicles, estrogen, steroid, corticosteroid.
You should remember, what is that known as?
Sir, Cushing syndrome.
Cushing syndrome. Cushing syndrome, you should keep it in mind and investigate further. Most of the time it is not found, but it is right. Okay, so now we have established. So the true cut report is there?
Yes, sir. Sir,
What does it show?
section from very tiny bit of tissue shows histology of fibrofatty tissue. No further opinion can be given.
So now it is established it is abnormal
Abnormal.
deposition. Okay. So now what we do?
Sir, yes, sir. If the patient is bothered cosmetically that she has a swelling, then we can offer a role of excision, or else we can give a trial of starvation prior to the surgery.
It is unilateral. The starvation is unlikely.
Unlikely. Sir,
Hormonal dysfunction
should be ruled out.
Yes, sir. Fine. What else?
After all these things, if patient is willing for surgery, then I would like to give her a trial of minimally invasive and excision.
Right?
Liposuction is one option for the patient, sir, which is minimally invasive.
Yes, if there is no tumor, liposuction has definite value. Right? Right now the tumor is not suggesting anything.
Yes, sir.
Is there now any role of incisional biopsy?
No, sir. No, sir.
Why?
Because we have taken image-guided true-cut biopsy, and unlikely that anything will be coming from incisional biopsy.
Once search is not captivated, it is diffused. MRI is also not something susceptible areas, and we have taken a core biopsy. Still there is no evidence of even a benign tumor, but incisional biopsy is not going to help. Suppose you do, patient says, I don't want to undergo liposuction. Is there any option?
Sir,
Open surgery has a value over.
excision of the swelling with white
What are the
margin.
disadvantages of that? You said I will offer minimally. Why?
Sir, skin will be preserved, and also contour will be not lost with the liposuction. symmetry will be maintained in liposuction, but when we are going for a excision, we will have to resect with wider margins and patient will have loss of contour over the
So
same.
create a symmetry is very difficult in a focal surgery. One. Second, size of incision will be very large. Third, there will be a lot of blood loss. Fourth, chances of skin necrosis and development of post-operative complications is very high. There will get discharge for a very long time again. That can also be liposuction, but that's it. That is a, so if it is all well defined, you can say either don't do anything or you should